Hi everybody, and welcome to our module on renal embryology. In terms of germ layers, the kidneys are derived in utero from the mesodermal germ layer, and what you have to understand kidney development in utero is that 3 embryonic renal structures form in utero, but the first 2 degenerate, and the third one goes on to become the adult kidney. The first kidney structure to form in utero is called the pronephros. This structure forms and it degenerates by week 4 early in the first trimester. The second kidney structure to form is called the mesonephros. This structure functions as the interim kidney in the first trimester, and then it degenerates, although it contributes to the vas deferens in males. The final kidney structure is called the metanephros. This is the structure that goes on to form the permanent kidney. It appears around the 5th week of development, and then it continues to develop into the kidney all the way through weeks 32 through 36 of gestation. And just so you have a picture of this in your mind, in utero there's a structure called the mesonephric duct. This is a structure that's very important to development of the genitals in males, and I talk about it a lot in the reproductive genital embryology videos. But the same structure forms in utero, and it has one end called the cranial end that's towards the head, and it has another end called the caudal end that is towards the tail. So up at this head end, you first have a renal structure form called the pronephros. It then degenerates. Then a second structure forms, and it also degenerates. And then finally, down here at the caudal end, we're going to have formation of the metanephros, which goes on to become the permanent adult kidney. So there are 2 key structures involved in forming the permanent adult kidney. The first one is called the ureteric bud. This is an outgrowth of the mesonephric or Wolffian duct, as I just showed in my drawing. It grows out of the caudal end of the mesonephric duct, and it will eventually give rise to much of the urinary collecting system, like the ureters, the urinary pelvis, the urinary calyces. Also, in terms of the nephrons, it gives rise to the collecting ducts, and I'll talk more about that in a minute. The second key structure is called metanephric mesenchyme. This is basically just mesoderm tissue that surrounds the ureteric bud. It's also sometimes called metanephric blastema. Unfortunately, it goes by a couple of names. And this tissue will interact with the ureteric bud, and that will give rise to the glomerulus and the distal tubules, all the portions of the nephron except for the collecting duct. And as we'll talk about later in this video, if the interaction between the metanephric mesenchyme and the ureteric bud is abnormal or aberrant, that leads to many kidney malformations. So here's a drawing of the nephron, and what you have in utero is a little bud coming off the mesonephric duct. That's called the ureteric bud, and it interacts with all this tissue surrounding it called the metanephric mesenchyme. The ureteric bud will form the collecting duct of the nephron, and it will also form much of the urinary collecting system. The metanephric mesenchyme, the tissue surrounding the ureteric bud, will form the proximal tubule and all the other parts of the nephron other than the collecting duct. There's a renal malignancy called Wilms tumor, which is the most common renal cancer of young children, and you should be aware that there's a tie-in with embryology here. This tumor is caused by an abnormal growth of the metanephric blastema. That's that tissue that surrounds the ureteric bud. This is capable of forming embryonic glomerular structures, and that's what you see when you do a biopsy of a Wilms tumor. It looks like what's shown on the screen here. All this purple stuff is embryonic glomerular structures, and this type of cancer is associated with mutations of a gene called WT1, and this is a gene that is normally expressed in metanephric blastema or metanephric mesenchyme. So all this should make sense to you now. This tumor is basically related to aberrancy of the embryologic structures in the kidney, and that's why it leads to tumors that occur in young children. Some children are born missing one or both kidneys. This is called renal agenesis. Basically, the kidney fails to form. And the cause of this problem is that the ureteric bud does not develop, and it never sends any signals to the mesenchyme, so you don't get a kidney. If this happens on only one side of the body, then a single kidney will be missing, and the remaining kidney will compensate. What happens is the other kidney undergoes hypertrophy and hyperfiltration, and this will basically serve to do the work of both kidneys so that these children are born normal and they are generally healthy. The major problem for these children born with one kidney is that there is a risk of renal failure decades later. They get a glomerular disease called focal segmental glomerulosclerosis, or FSGS, that I talk about in more detail in the videos on glomerular diseases. But it's very high yield to know that if a baby is born with one kidney, that's usually because their ureteric bud did not develop. That led to renal agenesis, and years later these children may get FSGS. Yes. Now, if both kidneys fail to develop, that's a big problem. The baby will have oligohydramnios and Potter syndrome, and we'll talk about these things later in this video. Another renal developmental anomaly is called multicystic dysplastic kidney. The cause of this problem is abnormal interactions between the ureteric bud and the mesenchyme. So if the ureteric bud doesn't form at all, you'll get renal agenesis. If it forms, but it interacts abnormally with the mesenchyme, you can get a multicystic dysplastic kidney. It's a form of renal dysplasia where the kidney is replaced with cysts. You can usually see it in utero on ultrasound. This is a picture of it shown on the screen here. There's usually no or little functioning renal tissue. It's usually unilateral and only affects one kidney, and this is in contrast to other cystic kidney diseases that are genetic in origin. Those typically affect both kidneys. If you look at this drawing of the kidney on the right, this is the pelvis of the kidney, and this is where the ureter attaches to the pelvis. This is called the ureteropelvic junction, and this is the last connection to form in utero of the urinary collecting system. And sometimes it does not form properly, and that leads to
bit of 100. Okay, I'm using it. Setting માં જાને output માં bitrate 100. Let's go. Just impress bitrate. Yeah. No worries.
ureteropelvic junction, or UPJ obstruction. This is a common cause of single kidney obstruction. So if you read a board question where one kidney is obstructed and swollen, that could be a UPJ obstruction. If both kidneys are swollen, it's probably something else. In this condition, there's a narrowing of the proximal ureter. That's the ureter right here, very close to the kidney, at the junction to the pelvis. It leads to hydronephrosis, which means a swollen kidney. This can often be detected in utero. And after birth, these children can have poor urinary flow because of this obstruction, and that can lead to an increased risk of kidney stones or urinary tract infections. And it can be treated, if needed, with surgery after birth. Let's
keep busy.
Take a look at this x-ray on the screen. The kidney on the left side has a single ureter draining down into the bladder. But if you look at the right side, you can see that there are two ureters that both drain to the bladder. This is called a duplex collecting system or a duplicated ureter. This problem occurs when two ureteric buds form on either the right side or the left side. It can also sometimes happen if one ureteric bud forms but then it bifurcates during development. What this leads to is a situation where on one side of the body there are basically a separate upper and lower kidney, each with their own drainage system. This can lead to poor urine flow, and that can lead to a swollen kidney or hydronephrosis. That also can increase the risk of urinary tract infections, and it's also associated with vesicoureteral reflux. So let's talk about what that is now. Vesicoureteral reflux is backward urine flow from the bladder to the kidneys. So if we have a right kidney and we have a left kidney and they both connect via the ureters down to the bladder, if there is a problem where the ureter inserts into the bladder here, then anytime the bladder contracts, instead of pushing urine out of the bladder, it will push it back up towards the kidneys. That's called vesicoureteral reflux, and it can happen if the ureter inserts abnormally here into the bladder on either side. The main clinical consequence of this problem is recurrent urinary tract infections. You need good flow of urine to keep bacteria out of the urinary tract. Vesicoureteral reflux is called primary vesicoureteral reflux when it's caused by abnormal closure of the ureterovesical junction, or the UVJ. This is where the ureter inserts into the bladder. This often occurs in children, and it's high yield to know that this is associated with duplex ureters. If the ureters form abnormally and they are duplex, they often insert abnormally into the bladder, and that often allows urine to leak backwards up towards the kidneys when the bladder contracts. There's also a form of vesicoureteral reflux that's called secondary. This happens anytime there's very high pressure in the bladder. If the pressure gets very high, then when the bladder contracts, it will push urine backwards up towards the kidneys. This is seen when there is an obstruction to the outflow of urine from the bladder, and one of the conditions that causes this that occurs in children is called posterior urethral valves, and we'll talk more about that in a minute. You can also see secondary reflux in men who have significant benign prostatic hyperplasia. Now let's talk about Potter syndrome, which is also called Potter sequence. This is a collection of abnormalities in a fetus that is caused when the fetus is exposed to absent or decreased amniotic fluid syndrome. Abdomen, these survive to birth before this often leads. In the first trimester, in the reproductive section, I talk about oligohydramnios, which is decreased amniotic fluid, and you should be aware that the causes vary by the trimester. So in the first trimester, which is the first 12 weeks, oligohydramnios is very rare. In the second trimester, which is everything up until 27 weeks, this is when oligohydramnios often occurs from decreased formation of fetal urine. The urine is very important in the second rupture. If ureteric bud does not form on both sides of the body, then the kidneys won't form. This is often detected in utero. The kidneys will not be seen on ultrasound. They're normally visible by 10 to 12 weeks, and these babies usually don't survive because there's no amniotic fluid. Another cause of Potter syndrome is called a posterior urethral valve. I also mentioned this earlier in the video. This only occurs in male babies, and the cause is a piece of tissue called a posterior urethral valve that obstructs the bladder outflow. If you look at this drawing on the screen, this is the bladder, and urine is supposed to flow out into the urethra in the male baby so it can go on to become amniotic fluid. If there's a piece of tissue right here, then urine cannot leave the bladder, and that will lead to fullness of the bladder and swelling of both kidneys, and this is called a posterior urethral valve, and this can lead to Potter syndrome. This is often detected on prenatal ultrasound. The baby will have a dilated bladder, and both kidneys will be dilated as well. And remember, both kidneys are affected. We talked earlier about some causes of hydronephrosis in one kidney. In this case, you have hydronephrosis of both kidneys. And when you see that described in fetus, especially if it's a male fetus, you should think of posterior urethral valves.
battery.
Another potential cause of Potter syndrome is autosomal recessive polycystic kidney disease. I talk about this in more detail in the video on cystic kidney disorders, but this is the juvenile form of cystic kidney disease that occurs in the fetus or in children. Cysts form in the kidneys and also in the biliary tree. Both kidneys are affected because it's a genetic disease, and if it's severe, it can cause oligohydramnios. If it's less severe, then it may cause renal failure and hypertension in childhood. Horseshoe kidney is a development because it's a genetic disease, and if it's severe, it can cause oligohydramnios. If it's diffuse, it looks like what's drawn on the screen here. You can see that the bottom or inferior portions of both kidneys are linked together. That's called a horseshoe kidney. When this happens, the kidneys cannot ascend in the pelvis, which they normally do during development, to rise up and settle in the retroperitoneum. They will therefore be lower down in the pelvis, and the reason for this is because they settle in the retroperitoneum. It's usually because of Vescan of Apicus. The urachus is an embryologic structure that connects the dome of the bladder to the umbilicus, and it should be a obliteration between the bladder and the umbilicus, then urine can leak from the umbilicus in a newborn baby. Also, sometimes if there's incomplete obliteration, a cyst or a sinus or a diverticulum can form, and these are setups for infections. Here are some drawings of urachal anomalies. This is a patent urachus, the bladder here. It's an adenocarcinoma of the bladder. Basically this bladder, and that concludes our video, is adenocarcinoma. What the question is likely going to ask you about is where did this come from? And the answer...
Okay, stream is healthy. Why? Hmm. Friend button, a friend button, so friend document. No, yes. Water. Is it? I didn't.
You can get a calculated as well. And remember, both kidneys are affected. We talked.
Me. So you get it. Px interpret of filtration rate.
Loop diuretics work in the thick ascending loop of Henle. If again I'm looking at the luminal membrane to the left, the pump that they're going to work on and block is the sodium-potassium dichloride symport. This is a pump that brings in sodium, potassium, and 2-chloride in order to have electron neutrality into the actual thick ascending loop cell, and then other pumps will bring those ions back into the blood. Now here's the issue. We know that inside a cell there is already high levels of potassium. So to try and bring more potassium in there works with electron neutrality, but certainly doesn't make sense when it comes to concentration gradients. This excess potassium will then leak, and this leakage is shown as the dotted line going back into the kidney tubule. Well, then this will cause, of course, an imbalance of charges. As the sodium and 2 chlorides keep on traveling through the cell, if potassium leaks back out, there will be a net positive potential from the gathering of positively charged potassium along that luminal membrane. Imagine that this is the actual tubule, and in that tubule you imagine linings of positive charges inside that tube. Now, what do you think an ion that is positively charged would feel like going into this tubule? Yeah, similar charges repel each other. So these positive ions refuse to go through that tubule. Look back at your diagram. This is what is shown with magnesium, calcium, trying to be shunted in between cells because of that positive potential. If you think of it, throughout that tubule we see a number of pumps for sodium, for potassium, for chloride, but no ions such as magnesium, calcium, certainly for other rare essential minerals that are important cofactors of enzyme, such as strontium, molybdenum, aluminium. So how on earth are we retaining these salts? Well, would you believe that most of these ions are not wasted by our kidney thanks to the positive potential exerted by that potassium leakage? Now put in your loop diuretic and block this pump. If you now block this pump, you know that you will no longer see that positive potential. So that besides having the classic effect of increasing excretion of sodium and potentially through dilution of amygdala then have a massive diuretic effect, I'm looking at a group of drugs that will cause all ions to be lost. That is, positive ions like sodium, potassium, but also those of magnesium, calcium, and surely eventually for electron neutrality, all negatively charged ions will just simply follow the positive charges. Essentially, I'm telling you that a loop diuretic will cause hypo every single ion in the body. Let's find some of this in our text. And first, let's identify that the initial loop diuretic was the drug ethacrylic acid, and the one that is most commonly used nowadays is the drug furosemide. If you knew also other loop diuretics such as torsemide, it wouldn't hurt. And certainly they're easily recognizable simply based on the similarity of name. So mechanism is the inhibition of the sodium-potassium 2-chloride transporter. And because of that inhibition, let's not forget that will decrease the back diffusion of potassium, decrease the positive potential, and decrease reabsorption of calcium and magnesium at the same time as we have an increased diuresis from the increased sodium excretion. These drugs are very much considered literally drug of choice in acute pulmonary edema. That is, the acute pulmonary edema, as you might see, in heart failure. So in our previous chapter, we were reviewing the drug digoxin and its inotropic activity, or other drugs preventing remodeling, such as ACE inhibitors, ARBs. Let's not forget that loop diuretics, such as furosemide, would be classically and conventionally part of the management of this patient's edema. What else could I use the drugs for? They're used for certain forms of renal failure. They can be used for anion overdose, and simply through the losses of positive charges, negatively charged organic molecule could follow, such as lactates, such as ketones. They are, of course, used in hypercalcemic states, since they cause a calcium loss that will allow decrease in that blood calcium. They have very much been used in any type of refractory edema, and then you
It's a big time break. Break. Here also, I don't know. Buffering. This internet. Okay. Nice. Very good. So they don't speak our language. Say.